So, all right. Well, let's get started then. So, my name is Dr. Ben England. I'm the CEO and one of the co-founders of Torrentia Medical Education, and I'm so excited to be joined by both Alicia and Mary. I'll pick on you a little bit from BCMS, a fun acronym that I recently learned about at a conference in Orlando. And I'm super excited to talk about what BCMS does, who BCMS is, and how they really can help practices, especially if you're a solo practitioner or you're just getting started in your practice, or maybe you just bought a new practice or thinking about it. These gals can answer pretty much any question you want when it comes to compliance and your business. So thank you, ladies, so much for being on here.
Thank you. Well, for starters, we were just talking about this 1 second ago, but like when I come to see you, we need to make a hype video like Ray did with you because a hype video for compliance would be awesome. Like, so I'm in. So thank you for
Absolutely.
Well, Miss Mary and Alicia, for both of you, how long have you both been working in the compliance business in terms of even just simple OSHA trainings? I mean, how long have you been involved in that?
Well, do you want me to really tell you?
You can take off about 20 years if you want.
Okay, so I'm in my 56th year as a PT. And actually, I started some OSHA work in the 90s, early 90s. Well, no, that's incorrect. I started my business in 85, BCMS, but it was the early 80s that I did some OSHA surveys. And it was actually for a practice, for a, yeah, it was a practice management type of company. But anyway, so had a practice, sold the practice, said, what do I want to do when I grow up? And I said, I want to make it easier for people to deal with regulations that are still actively treating patients because it's so much. And that's really what the gist was behind it. So that's been since 2020. And
no,
Alicia's been with,
2000, since
I mean,
2000.
2000, excuse me, 2000.
I'm like, you
I
just took
told her
20 years off of our.
I told her to
Yeah,
take 20 years off. It's okay.
yeah. He told me 20 years. There you go.
Yes.
So, and Alicia's been with us.
Yeah.
Tell
Well,
us
off
how.
and on my whole life. I worked at my mom's clinic and then I started as a consultant in 2011, but I've been with BCMS since 14. So um, I've seen a lot of compliance and it's actually very fulfilling.
Awesome. Well, that's cool. Well, as you said before, Alicia, many times your goal is not to scare people when it comes to compliance.
Yeah.
It's not something as a business owner that we typically like to talk about because generally when we are, it generally has a negative connotation to it. If you're pulling out your policy and procedure manual to look at something that maybe happened or didn't happen, or maybe there was an incident, it's never a fun experience for many people. So the goal of this is not to scare people, to not
Yeah.
make people feel unsettled,
Yeah.
but I really want it to be a good discussion on how practices can prepare, especially moving into 2026. We just shot a podcast and webinar last week on ethics and compliance and why it's important this year. As practices are adding cash-based services, it's critical, not maybe okay, maybe you need it. It is critical and imperative that practices prepare, especially as profit margins get razor thin with insurance companies. We're starting to see more and more audits in different areas. So we're really just trying to be on the forefront of it as opposed to reactive. So what are some of the areas that you feel maybe your small businesses or startup practices are struggling with when it comes to compliance?
Well, it's funny that you bring this up because small practices and especially cash-based practices often think compliance doesn't apply to them. They're like, you know what? I don't see Medicare patients, so I don't have to deal with all of that stuff. And the reality is that's just one small portion of what we're supposed to have in place. I mean, we've
Yep.
got OSHA, we've got HIPAA, we've got non-discrimination, we've got your, employee personnel, we've got your Practice Act. I mean, so there's quite a bit. Um, I wouldn't say that there's one, the thing that I would say probably the most is they have a hard time putting a foundation in place.
Hmm.
Is they don't know what to do or what to put into place. And so that's probably where I think the hardest thing is for a practice is because they went to school to heal people, not to read regulation. So really that's kind of what we see the most with that.
Okay. Mary, anything to add to that? I mean, over the years, things I'm sure have changed, but I'm sure nowadays, more and more, there are different struggles that are erupting in 25 and 2026.
Well, and you're right. Alicia, hit the key things. I would say over the course of things, the thing we get the most pushback on is OSHA. No, that's hospitals. We
Yeah.
don't have to deal with it, even down to bloodborne pathogens, which applies to obviously outpatient facilities. So that's probably where we originally got the most pushback.
Mhm.
HIPAA is there. People understand they have to comply with HIPAA.
Yep.
Mhm.
That's not a big deal. But as she said, everyone thinks, well, I'm such a small, cog in the wheel. It doesn't apply. And many people look at compliance only from the payer perspective. And
Mhm.
once they eliminate the dragon in the woods, they think they're free and clear. And that's where we run into some issues. And we can talk about, I don't know, Alicia, do you want to get into the anti-kickback and the illegal remuneration now, or do you want to wait?
We can, I mean, let's ease into this so that they don't
Yeah.
hear us talk the words illegal first or yet.
Well, I mean, I'm going to say the A word. I mean, we're going to jump right into audits. Where do you
Yeah.
see audits occurring the most frequently?
It's so funny because there's really kind of when it comes to there's really audits and there's also investigations. And
Mhm.
so with audits, that's typically what you think. It's tied to your MPI number. You did something different or more aberrant than your peers, and so it causes an audit. This is usually from CMS or MAC, and that's going to come and really they're looking at that. But we also see investigations. And so with investigations, that's typically from a whistleblower. And who are
Mhm.
whistleblowers? Employees,
Right.
patients. And so, and these things are really relative again to that OSHA and HIPAA. And a lot of people don't think about it, but like OSHA is actually really relative to the employee, not to a patient. People think, oh, it's for patient safety. It's actually not. It's the employees. And so when employees whistleblowing, it's because they're fearful and they are concerned. And so we saw a ton of investigations during COVID.
Yep.
People were reporting their practices left and right. And so those are the kind of things that we've seen. You don't see as many HIPAA like whistleblowing as I, recently with OSHA, but like definitely you see the same thing that the
Yep.
employee is looking and saying, what are we doing? We don't have encryption. We don't do this. I really feel uncomfortable with how this is proceeding. And that's kind of where those things are kind of popping up.
Sure. I know some of the big ones that I've seen, especially when you talk about whistleblowers, is maybe there's a piece of equipment that has a tear in it, or
Yeah.
something that,
Right.
I see that because I get to travel around to clinics all over the U.S. and it's generally like a love tap before I leave. I'm like, hey, just letting you know, you might want to get that looked at. And many times people look at me like I'm crazy. And it's like, I'm not trying to be the bearer of bad news, but you might want to check on some things. And it's
Mhm.
amazing how easy it is to overlook those things when you're in a practice day to day.
Well, and
Absolutely.
that's something that we have done for years. In fact, it was our bread and butter for a long time was to do site surveys. And this was the entire physical plant. We also did chart audits. We did interviews with the business office staff, with the staff on occasion, your clinical staff, and then HR,
Yep.
because people's HR records are disastrous. And they
If
can't,
they have them.
yes,
Right?
if they
Exactly.
have them, if they have them, that is so correct. But people, I said, okay, don't be offended. We're going to look in your cabinets. Yes, we're going to look for tears. We're going to look for calibration records. We're going to look at all of these things. And they go, this can't be this. We can't have to comply with all this. You get the, I don't believe this, you know. But we try to go in as proactive as we can and provide the tools to help them do it in a very clear and, user-friendly manner. But that is the thing. And definitely, if you've done site visits and you go in, um, there's all kinds of things you will certainly see.
Yeah.
Most
Well, I always
definitely.
tell people that we actually aren't the bad guys. We're the ones who are here to protect you. So when we're telling you stuff, we're not going to go and turn you in. We're here to tell you, hey, these are things. So we kind of look at it more as again, proactive versus reactive, and just really getting that infrastructure in place.
That's
And
awesome.
I think one thing that people don't understand, and I'm going to go back to audits, is that starts at the claims level. So that what story the claims tells is what is happening when they do all the analytics on the data.
Mhm.
And so if you are a redundant coder, if ignore your denials, those types of things, all of that tells a story. All of that starts the probing. And we see that. As we said, we typically don't see people turning you in and causing an audit. It's usually what happens at that claims level, unless you're so fortunate to get a cert audit, and that's just a random selection. But
I've
most audits
Right.
are targeted.
I've had the privilege of one of those before.
A cert, yeah.
Yes.
And it used to be, it was stated that it was educational, but
Hmm.
now it has far more implications because they usually refer them on if they see egregious
Right.
behavior.
Yep. Yeah, and my experience was okay with it. I mean, they came in, they did a sampling of, I think, I forget, 10 or 20 patient charts, looked through, made sure things were compliant. They gave us heads up. They came in and said, "Hey, we're coming in to do this,"
Okay.
which was I thought was nice. So,
Yeah.
um,
Yeah, well,
That's very nice of them.
typically cert audits are random and they don't give you notice.
Good for
yep.
you.
So
Good for
you're a
you.
lucky boy.
Yes, I was. It was a very busy day that day, so
Of
I was
course,
very grateful.
of
Absolutely.
course.
So, well, I'm going to jump in and ask a really big question because I get to travel around. I've been in a lot of cash-based practices. I've seen clinics that only offer cash services in gyms and different situations, as well as practices that dabble in what we call hybrid. So they're a typical insurance payer model, but they've added a new service, whether that's hyperbaric oxygen, class 4 laser, et cetera. And the practice owner goes, "Wow, I want to get a lot of people through my door. We're just going to offer our services for free." Um, what are some things that you see in terms of things that are okay versus maybe what's not okay or generally safe to offer when you're looking at doing that? Because a lot of marketing, and I see this around my town, is the marketing of services doesn't always match the FDA approval for certain things, and it creates a problem, right? Like, because you want to make sure that you're being compliant and ethically advertising what you're doing. So I'll just let you talk. I know it's a really hot button topic, so please feel free to chat about it.
I'm going to defer to Alicia to some degree, but one thing I want to say is, we love our vendors. They work hard, they provide great service to us, but they aren't the experts in how to bill for services, and they also aren't compliance,
Right.
experts. So they may tell you certain things are appropriate and you can do certain things
Yep.
when it is not, legal. And you have to be aware of that. So don't get your guidance from your vendors for those types of things. Get the guidance for how to do it in the best way to perform that intervention.
And
Yeah.
it's so funny, Ben, because literally when you and I were talking before we started, we were on with a client this morning, literally talking about this exact thing. And they
Yep.
are a hybrid. They are, primarily a normal, Medicare taking, insurance.
Fee for service, yeah.
Yeah,
Yep.
but they have quite a few of these products that we're all talking about. And so really, if I were to start out, I would say there's the overriding federal anti-kickback rules. Okay. And that's the federal ones. That's if you take any of these insurances, Medicare, Medicare Advantage, TRICARE, et cetera, Medicaid. Okay. And so basically the anti-kickback statute is like a federal law that prohibits offering, paying, soliciting, or receiving anything of value in exchange for patient referrals or services paid by these federal healthcare programs. And so I wanted to at least explain that so that people understand what anti-kickback is, because they're really trying to make sure that you're not inducing.
Correct.
And so that's where this can get really interesting, because if you are not if you're not accepting Medicare and you are a cash service, you think I'm fine. And so you're like, I don't have to deal with that federal. But then you go down to the state level. And now there's often states that mirror anti-kickback. And then there's others that do something called illegal remuneration. And that basically feels very similar to anti-kickback. It's the same thing. And it's payments or anything of value, whether it's cash or in kind, are offered and received directly or indirectly. So it's the same kind of vibe where you're inducing or rewarding for referrals and purchases. And so again, that doesn't even matter if you are taking Medicare.
Right.
You're still now dealing on the state level if that state has it. Now, we have researched this. There is only one state that does not have anti-kickback or illegal remuneration, and that is Maine. So if you want to do cash-based services and just run free, move to Maine. So we do that. But the statutes that we're in, I mean, and I'll let my mom get into a little bit more detail here, but like I always look at things from a risk standpoint.
Right.
I am a low risk gal. I don't like laying awake at night. I want to do things right. And so really, if you're going to do cash-based services and do it right, low risk would be things like providing like a flat discount. So this is things like where you have your usual and customary and you reduce it by a percentage and you're consistent across the board. And that can be hey, this is our discounted cash price, which sounds good. And it's also correct. And then, there's also things like, when you have transparent bundle pricing, we have 10 lasers for $100 or whatever. And so again, post it, it's clear. There's no, confusion on what you're offering. And the last one is one that a lot of people don't think about, but it really can actually be helpful for patients, which is a payment plan. Because there's some patients who are going to see these services as a cash service and they're like, I can't afford this, but I want it. I want to get laser because I need this. And you said it's going to help stimulate the tissue and, whatnot. And so that's where you would need to offer them a payment plan that you would want to make sure that it's very clear and that they could pay over time. So those are kind of some low risks, high risks. And we see a lot of these. And so I'm sorry, anybody listening that, but when you say
the fun sponge.
I know it's terrible. Like one of our clients literally nicknamed me the fun sponge, like probably 7 years ago. And we actually had a Halloween conference that we went to. And everybody calls my mother the queen of compliance. And so she was so lovely and dressed with her crown and gape. And I was dressed like SpongeBob.
Because she just sucks all the fun out of everything.
I know, sorry. So with high risk ones, just to give you some examples, when you're offering free service, and this would be like, hey, I am getting treated for low back pain, but we're going to offer you free laser so you can see if you like it. And then you can get into a package of some kind. And that's where you start to have that risk. Or you have incentives for your therapist where you're like, hey, if you, help us get this many lasers, X, Y, and Z, well, that could influence their clinical decision-making. And so that again, and then, also that could pressure patients into, additional services. So really those are kind of high risk. I don't know, Mary, if you want to give some more good details for either of those,
Well,
or
we
examples.
certainly, when we talk about the free services, and I understand the from a clinical perspective that you want patients to feel comfortable with your interventions. But I always, and the question I always ask people, they say, well, we're going to offer them a few trials so they can determine whether they like it or not. Well, do we do that for exercise? Do we do it for manual therapy? Do we say, oh, if you don't like it, you don't have to pay for it? Or I think we'll do the first two or three free. We don't do that. So why do we offer that? Now, I understand these are non-covered services and manual therapy and exercise are covered, but it's still, from a clinical perspective, it doesn't make sense. When the payers or the states, like under the illegal remuneration provisions, look at this, they're always looking at enticement
Mm-hmm.
and that the patient respects you, they value your opinion, and you doing this is going to encourage them to, again, purchase more, engage in more. And so offering free anything, okay,
Yep.
is really prohibited. There, there are a few exceptions. For instance, you can offer free transportation, but it has a number of requirements.
Yeah.
It
Mm-hmm.
has to be offered in a specific service area. It has to be offered to everyone. You
Yep.
cannot advertise free on the van. There's all kinds of things like that. So there are a few areas. Free workshops are fine.
Mm-hmm.
Okay. However, there's a caveat there. If it's a federally reimbursed plan that the patient is associated with, let's say they're Medicare, the government would not want you to do your education and have a lineup for scheduling them for a visit. They would want to give the patient an opportunity to think about it so it's not a pressure sale.
Mm-hmm.
Maybe ask their physician if they want to, but a lot of these patients are direct access and they don't necessarily want to engage the physician, but it's it's different for Medicare because you need to step back on those and not tie that free service education you just gave them to okay, now here it comes. We want to treat you. We're going to make money from based on federal funds and go from there. So
Right.
you have to segregate those. Um, I I would encourage anyone who's listening who has, the free trials and all that to really think very, very seriously about the risk
Mm-hmm.
because and to know their state law. If they live in Maine, they're okay. But
Yep.
if they don't live in Maine and they have consumer protection laws, they have anything that has to do with rebates and the basis of illegal remuneration, you put yourself at risk.
Yep.
And in most cases, our patients aren't the villains. They don't turn us in. But guess who it does? If these people happen to have parents or they are the children of older parents or whatever, they're the ones that say they shouldn't have had to pay for this or they were enticed to
Yep.
do this, So that's where we get complaints and we get people turned in to different entities that can enforce these laws.
And Ben, I have to just put a big explanation point on how excited we are that we are engaging with a partnership with you guys because
Yeah.
we truly believe in cash-based services.
Mm-hmm.
We believe in it so vehemently because sustainability alone and also just the quality of care that
Yep.
we're seeing with a lot of these services. And so us being able to partner with such an exceptional, education arm and
Yep.
be able to really have a voice to help these practices who are, really engaged with you is exciting for us. And
We
so,
can teach you to do it right
Yep.
yeah,
and to sustain to more than, we want you to thrive, not survive. So
absolutely.
Yep.
we don't want them to take money away that you've earned
Yes.
through fines and penalties, because these laws all have fines and penalties. So we
Yep.
want to make sure that we can give you the opportunity to understand where your risks are
Yeah. Well,
and to stay in that low risk area.
we're super excited too. I mean, Dr. Ray, my other colleague here on the call, he and I started Torrentia, and we really wanted all of our classes. When we teach providers about these technologies, we teach them the literature so that their recommendations to patients are founded in research.
Right.
Meaning, the FDA approves, Achilles tendinosis, Achilles tendonitis. It's about 3 to 6 visits of shockwave, so the providers aren't recommending a 20 visit package. The providers
Right.
are,
There
as
you
Ray has
are.
shockwave there,
There he is.
you know.
I'm literally shockwaving during the webinar.
Oh my gosh.
That's
So,
fantastic.
Nice to meet you guys.
Very nice to
no, the
meet you again.
shockwave, the shockwave most definitely, so the providers know we're making an ethical decision based off of what the research says, not because my boss wants me to bill more. And the other side of that is when we go and get to work with a lot of these large practices and some of these practices with 6 to 50 clinics, and they say, hey, we want to roll out they use the term incentive plan, or we want to roll out a employee motivation plan, or however they want to call it. My comment deferral is always, well, then I want you to list out every, ICD-10 code, list out every diagnosis, and we will come up with an ethical plan for each and every one of those things. They're like, well, that'll take forever. The point of this is that your providers make their best recommendation based on research, not on a high pressure sale. Um, so,
Absolutely. Oh, I
um,
love that. That's great.
yeah, so we're super excited, and that was what Carl and Chad at Breakthrough, asked me to kind of talk about it at the conference was really how do you motivate? Like this was the question: is everybody in the room? How do we motivate our staff to sell more? I don't like that very much, but what I do like is it's easy. You educate the staff on what the research says. Because if they know what the research says, then they're making ethical recommendations and they can sleep well at night, for, whatever reason, if we're making a recommendation to somebody. And I do agree with you on, if you're doing a lot of these workshops and, reactivating past patients and other things, I'm all for that. But you do have to make sure that it is educational, informative, and in the patient's best interest. We use shockwave and laser in
Okay.
practice because it accelerates our outcomes. Like we advertise quite
Wow.
a bit. It's a 33% faster outcome. So if a patient's coming in our clinic and it may have taken 12 visits just using conservative care, well, now we're looking more at, 6 or 8 visits for, their care. So while they are paying more because they have, are using some of these cash services, their outcomes are faster,
And in
so
the
it's
long run, probably paying less.
correct. And that's
Not to
exactly what we do.
mention, how they feel when they're not, experiencing the best care or the most expedited quality care. And that's what we really pride ourselves on when when we speak to our clients or to the public, it is based on vetted research.
Hmm.
We don't go out and this is Mary's opinion or this is Elise's opinion. Okay.
Yeah.
We don't do that. We have had debates. We've had screaming and hollering
Yeah.
sessions with people, but everybody does it this way. This isn't possible. There's
Yeah.
Right.
no way we can do that, but there is.
Yeah.
And you want to keep the money you earn.
Hmm.
Yeah. I get told often when I first talk to somebody who's interested in just kind of our offerings and whatnot, when they understand compliance as a whole, they're like, you just gave me a project. And I'm like, actually, no, we're here to provide you infrastructure. It's just like when you
Hmm.
built your house, you have a foundation. Like all we want to do is provide you with a safety net. because that's what we're here for. And so this is such a cool alliance. It's going to be a lot of fun. I'm really
Well,
excited.
and we do the groundwork. Okay,
Yes.
we're doing the shoveling of the dirt.
Yes.
They implement. Okay,
Yes.
they get to decorate.
Yeah, I like that.
So, that's what we want to do. We want to facilitate it. We want to give them the information so they understand why they're doing it. No one likes to do things just because. However, in the reverse, people will tell us, well, everybody does it that way. And I'll say, do they have a reason for why they did it that way? And they'll say, well, just because. Well, that just because isn't going to work.
Yeah. Well, I'm going to shift gears just a little bit, talking about, different cash services and other things. I get asked this question a lot, Alicia. I know you get asked this question a lot in terms of consent forms for dry needling. You should definitely have them. You should check
Absolutely.
your state scope of practice. Are
Yes.
you or aren't you allowed to do it? But then also, a lot of states require OSHA bloodborne pathogen training, and many of them, I know Georgia is one of them, that students are actually required to file their OSHA certificate that they completed the training when they apply to the state to be able to do dry needling. So
Mhm.
I'll let you talk a little bit about it, because I've heard some people say you absolutely have to have it. I've heard some people say, well, it's really your risk tolerance. Maybe my consent form for my clinic blankets, that.
Sure.
Just as one example to show maybe some of the individuals on the call how BCMS can partner with the clinic to really help navigate, we'll just call it a common question, right?
Sure. Well, I
So
think
it's
the first thing, oh, go ahead, Alicia.
Oh, it's okay. So basically, OSHA requires bloodborne pathogen education, period, because you are a healthcare provider who has the potential to be exposed to bloodborne pathogens, et cetera. So, like, that's required regardless of whether you do dry needling or not. So we can start there. But really, where I've seen, and I can let you rubber stamp this, Mary, but where I've seen the most requirement is liability insurance.
Mm-hmm.
Like, they want to see these certificates as part of that. And we have quite a few clients who they specifically ask for our education to provide that, because that's where they're putting it. And so, and it's funny you say Georgia, because we have a very large one that we do a whole lot of that for. So, Mary, if you want to rubber stamp or add too, for sure.
Well, I think we have to go to the practice acts.
Yeah.
Some practice acts do require validation and of coursework. They require consent forms. I have not read every single practice act dry needling. I have read every single practice act at least once,
Oh,
but they do change.
Yep.
So we have to be aware of that. But there are many that do. We provide some sample ones, but we tweak them. We're going to tweak based on state law and also where we feel there are vulnerabilities too. Patient information is going to be critical. So giving the appropriate in-depth, easy reading, though, so they can understand it, not too complex.
Sure.
We often will throw our forms into one of the 3 or 4 AI tools that we use and say, could you drop this to a 10th grade level?
Yep.
Yeah.
Because it's important when you start talking about these things, they don't understand it. And so it's not valuable. You're getting the consent so that they understand. And so we, look at it from that perspective. We have a lot of focus on education as far as needle handling, infection control, um, and those types of things that is beyond the bloodborne pathogens. But you want to know, proper sharps management, sharps injury reporting, all of those types of things have to be built into it. And so that is what our program provides. We have a ton of resources. So if people really like to read when they're, in bed, there's a lot of reading that they can access. But it is critically important that the consumer, our patients, understand what we're doing. That's what the consent is for. It's not to be written in legalese that you need somebody other than an attorney to interpret.
Sure. Yeah, the other question I get a lot is in regards to ABN forms or advanced beneficiary notices. Do you
Yeah.
maybe want to tease a little bit about that?
I
Maybe not.
will definitely handle that one. Okay. And I just had that um, question come in from one of our clients in Minnesota. And they said, how do we fill this out? What option? What if they choose this or that? And I said, and you're talking about dry needling, right? And they said, yes. And I said, well, dry needling is not a covered service. And they said, yes. And I said, so you don't need an ABN. And they're going, oh, no, no. We read that you have to have an ABN. Well, you do not have to have an ABN. We have information directly from CMS that addresses that, and it states clearly if it is not a covered service, there's no ABN. Do we recommend an ABN? Yes, on a voluntary basis. The voluntary basis, the
Ben,
voluntary
you were
basis,
waiting for that, right?
yes,
Right.
It's the silver
listen,
bullet.
it is.
It ensures the patient knows that they are going to pay for that service.
That's
So,
exactly right.
absolutely.
So, and there's another opportunity to use an ABN. For instance, if you do have, I'm not going to set most supplemental coverage. And so if we're talking Medicare because we're talking
Mhm.
about the specific
Yep.
ABN. Um, Most of them will not cover for services that are not covered by Medicare. But there are a lot of people that have tertiary coverage.
Yep.
And there is a possibility that it could be. So you could, again,
Mhm.
have an ABN and affix the GY modifier. And that indicates we know it's not covered. We're doing this for a forced denial from Medicare. And then that could be submitted to that tertiary
Yep.
payer. But there is no requirement for an ABN. There was some misunderstanding. Um, it was, I think, based on the fact that there is an LCD
Mhm.
for chronic low back coverage, and so Medicare will pay for it, but it is only specific people, acupuncturists, people certified to deliver acupuncture. But it is for dry needling, and therapists are specifically excluded from it.
Right.
And so, again, people go, well, then do we have to do an ABN? Well, if you're excluded from it, it's not a covered service.
Yeah.
Right.
Well,
So how can therapists be prepared? I mean, when you have just one provider in your practice like I do now versus when, I had 20 providers in my practice.
Mm-hmm.
Every year Medicare releases a nice fancy document of all the updates to, the CMS and updates and changes
Physician
and
fee schedule.
the
yeah.
new fee schedules. And you
Yeah.
always hear about it from the national associations. Oh, we're fighting the cut or we're asking for this subsection to be removed. How can you, I mean, I know why I like BCMS, which is you take the guesswork out of it. But how can therapists really prepare, especially business owners, because we have a lot of private practice owners in the Torrentia tribe who they're just trying to make it. They're
Yeah.
trying to make it right now. How can they prepare?
So I'm going to take this one.
Yeah,
So
Alicia, definitely.
really, there is again, a rule of thumb. If you weren't, okay, like our client, which we're hoping at some point we can certainly talk about that stuff. But if you
Mhm.
weren't, there's really some rules of thumb that you want to have centralized elements that you would address. There's 7 of them. And I know that that's a lot, and I'm happy to send that to people, but this is going to give you kind of
Mhm.
guidance amongst any of your risk areas. Okay, so the first is that you have oversight. So this is going to be that you have said somebody is going to oversee compliance. A lot of times it's the clinic owner, but it certainly can be anyone that you designate that you feel is the right for that job.
So
Um,
hire a fund sponge. Got it.
yes, hire a funds fund. Hire somebody who loves
New
attention to
title. We won't call them a compliance officer.
right, right. The second is having written policies and procedures,
Mhm.
and for real. And by the way, ones that your like staff can access, because that's half the battle. Like a lot of people have, oh, I have an OSHA binder that's sitting over here, or I've got a handbook, and you're like,
And
I
it's
want to
locked
see
in
it.
the owner's office.
Yeah, I'm like, I want to see the dress code. What is, so like
Mhm.
number two is policies and procedures. Number three is training and education. I'm literally talking to education master here. So most of the people who are listening to this understand the importance of that one. The fourth is really having effective lines of communication. We talked earlier about some of that whistleblowing. This is a big one for that. If you have a good lines of communication with your staff and they feel that they can talk to you about their concerns or how to do things and understanding the regulations and what needs to be in place, changes a whole lot of the dimension of the practice and in
Yep.
that one particularly.
And if you hear them out, because they may come with different perceptions.
Exactly. Exactly.
Right.
And then five is going to be monitoring and auditing. So again, a lot of people say, I had policies and procedures, or I did this when I first started, but then they've never done anything with it for the next, 5 years. The last is like, again, we're getting into kind of some of the, but it's enforcing and really disciplinary guidelines.
Mhm.
Like these are things you need to have written out and really have structured, because if they don't understand that they're doing
Yep.
something incorrect or vice versa, then they will not do it right. And the last is when you see stuff that you get prompt corrective action. So, and those
And
are really,
documented.
and document it, everything, document everything. And so those are really seven guidelines, again, that the OIG says, that, like these are things that are kind of standard for a compliance program,
Mhm.
but that's a breakdown in the simplest terms that you can probably put it in.
Yeah.
And what that demonstrates to the regulators, whichever regulator it is,
Mhm.
it demonstrates that you've made an effort. They do look, especially with HIPAA, at size and your capabilities or your lack of capabilities to fulfill, a robust, HIPAA compliance program. But they look at it, and in many, many cases, they will give you credit basically for that. That doesn't mean they forgive everything. That doesn't mean every final penalty will go away. But if it was going to be gigantic, it might be much smaller. When it comes to OSHA, they're more lenient than HIPAA. But they certainly do levy fines and penalties. But I think showing the effort that you kind of have that system in place. What's difficult is where do you get the information that you develop the policies and procedures from?
Yep.
And I will tell you, please do not rely on your AI sources, okay? Because I have battles with them every day.
Yeah.
I'll throw a question in and they'll blah, 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 and I'll say, why don't you go back and look at CFR X, Y, and Z? And then it comes back, we are updating our information now.
Right.
So
Yeah.
it might be a good tool to refine your policies and procedures, but it is not the all, end all for everything.
I was talking with a private practice owner. He called me at the end of last week, and he had really started his own practice. He was just in process of actually just had another therapist, and he was getting ready to hire a third therapist, in his clinic. And I asked him how things were going, and he said, "Well, I just wrote a really big check." And I said, "For what?" He goes, "Well, I hired an attorney because I realized when it was just me, things were simple. And now I'm up to date with up to code, up to all of this stuff." And I said, "Why didn't you call me a week sooner?"
I know.
He spent all
That's
this
expensive.
money on, attorneys to build his, policy manuals and all of this. And you really, with BCMS, I mean, from what I've seen, you guys have it all, 500 plus pages and documents for practices. You keep it all in one place. Alicia shared with me the bubble that you guys have.
Yep.
And it's really kind of your fortress of solitude and your your fortress for your clinic of making sure you don't miss things. It's a way of training a chief fun sponge in
Mhm.
your clinic. And I was
Yes.
really impressed because, I mean, once again, I was at a clinic earlier this year or last year, 2025. Alicia, I told you, I walked in, asked to help out implementing shockwave and laser services into their clinic. And I said, I'm more than happy to. And I said, can I see your policy and procedure manual? And they looked at me like I had four heads.
Uh-huh.
And I'm like, a clinic this size and you don't have policies? And it was maybe 2 or 3 pages that were thrown together the day that the clinic opened. And
Yeah.
you're talking 30 plus staff. I
Oh,
mean, I said, I need you to do something different, you know, and I
mhm.
think they kind of heard that as I don't really need to do all that. So I'm just waiting for them to call back when they have a problem and I'm going to throw throw them your way.
Well, and the issue is, Ben, is that they don't realize the liability that they have in their hands because they have 30 people or more
Mhm.
doing it their own way.
Yeah.
Right.
And, that puts you in harm's way without question. There's got to be consistency. It's got to be based on, as you said, vetted or valid, resources and research. Um, if they really thought about the liability perspective. They maybe behave better. We've seen everything. We've seen, oh, I had this, I kind of lifted this from the hospital when I worked at the hospital, or whatever. So it's very, very important that they understand that the consistency that you get from having those in place.
Well, and I appreciate, Ben, you even bringing up the bubble. It's been really fun to actually evolve. BCMS has been providing compliance and compliance programs for 26 years, not
Right.
not six,
Not
26
six.
years. And so, and we finally really have a solution that tracks everything, it documents everything. It really covers the two governing bodies. The last thing we want to talk about, but we really do address the Department of Health and Human Services, Medicare, fraud and abuse, non-discrimination, all of those, HIPAA, and then also the Department of Labor. And so we talk about your people. We've got your OSHA, we've got your, handbook, and we're industry specific. And so that's really where we really have a specialty is that we're talking in your language. And a lot of times you go to an attorney like this guy did, and
Yep.
they are a healthcare attorney and they don't even address a lot of the things that are needed to be addressed. And so,
They've never been in the clinic. They don't
yeah, they've never been
understand,
there.
you know.
Exactly. So thank you. Yes, appreciate that.
Yeah, well, I'll throw up a link here, for all of the people that are on. I know there's quite a few in the tribe. I know there's some here on the call here, just to BCMS's website and really just get involved, reach out to Alicia. I know she's always been really up for talking and chatting, and we're really excited, with Torrentia to be partnering with BCMS in a number of different ways that you'll see kind of roll out as this year goes on, and really just making sure that each and everything that we do, not just from a continuing education standpoint, but really as we're giving recommendations to students on courses going back to their clinic, they may find that the work environment that they're working in may not exactly be the most ethical place for them from a compliance standpoint. And it's really okay until it's your license.
Right.
And the number of times that I've shared that, David, you're one of my fellows, and others, that are in the tribe right now, you really know that I'm big on it's okay to do it until it's your license, and making sure that things are above board. Like I had a physician in my past office, and we were very cautious of, okay, number of internal referrals versus external referrals and tracking that monthly. And as much as that seems like a painstaking, activity,
Yeah.
it was all for legal and compliant reasons. It was,
Right.
okay, there's a doctor, he could refer 100%, but we can't do that. You have to be above board and make sure those things are right because it's my license or his license or someone else's license
That's
because
exactly right.
somebody's got to be holding the bag, right?
Yeah.
Somebody has
We
to be
have to always think of consequences,
Yeah.
and the more proactive we can be, the fewer consequences we hope we will have to deal with.
right.
One
Absolutely.
thing I do want to say, when people worry about policies and procedures, and for instance, our bubble, one of the things that we do is we do help you understand the policies. Now, we do separate consultations if you have unique situations that really
Sure.
fall out of the policy, like you want to carve out something. But we do support them. If we have people call Alicia constantly on, I don't understand the ABN policy.
Yeah.
And we've got it down to pretty plain language, but I don't, because they have so much other information come in. So we want to make certain that we are as clear as we can. We'll provide them with resources like the CMS Q&A on ABNs. We'll provide them with some legal resources where they address certain things. So we do try to provide additional resources. So not only can we prove that what we're telling them is accurate, but they can satisfy, their quest for understanding.
No, that's awesome.
Absolutely.
Well, Alicia and Mary, thank you so much for being on. I do enjoy speaking with you and talking with you. I'm
Thank
so glad that
you.
our paths crossed in 2025, and I really do
Yeah,
look forward to 2026 and beyond. That was sort of our theme
absolutely.
this month. And
Absolutely. Well, we're very excited. Thank you for this opportunity to interact with the tribe. I was in there today, and it is like great energy. I'm very excited about it. So, looking forward to the next steps for sure.
awesome. Well, thank you, ladies, so much. If anybody has any questions, please feel free to reach out. You can always get in contact with me via the Torrentia tribe. And then for anybody that needs Alicia, I think she threw her email up in the group chat.
I
And you
did.
should be able to get in contact with her. I threw their website on there, and you can check out the compliance bubble. And coming soon, my hope is to have a Torrentia tribe compliance bubble that they can click on, and it goes directly to the tribe or to the bubble login because I do really believe in compliance, especially as private practices are going out on their own, and you're seeing more and more solopreneurs and individuals creating their own businesses and kind of moving towards this cash model. It's really important to make sure your I's are dotted and your T's are crossed because one lawsuit can bury you, two can bankrupt you, and three can end you. I mean, it really
Yeah.
is not something to mess around with. It's not to make anybody fearful, but it can be a headache, and these ladies have done a great job of preventing headaches.
Yes. We want to lead you down the correct path and for
That's
you to
Awesome.
great.
sleep at night.
Well,
And
thank you
Ray, it
so
was
much.
nice seeing you for a hot second too.
He might get on. We'll see.
Yeah.
Yeah.
He's we're all busy. He's down in Miami. We're getting ready to go to CSM next week. Combined sections meetings is coming up, and we're
Yeah.
looking forward to being there. So
Absolutely.
Yeah.
Well,
Jody will be there. So,
I'll look forward to seeing him.
yeah,
awesome.
absolutely.
Awesome. Thank
Well,
you so much, Ben. You have a great evening.
you too, ladies. Thank you.
It's been a
Bye.
pleasure.